Hello, dear candidates. As this class is going to be recorded, so we will be sharing it in our groups. So I'm just starting because this is a very crucial time. You have just 1 month before exam. And in every exam, what we do before 1 month, we specifically tell you what are the topics that are important for this September, and you study those topics only again and again. No detailed explanation here because already everything has been detailedly explained in our classes and in our recalls classes. So giving details will just waste your time right now. So what you do, I will not take much time. I will be pointing out the important topics for this September exam, and what I said in class, what to study from those things, you just study those things. So I'm going to start. ASS score is very important, and I'll be giving a final suggestion specifically with questions answers. With questions answers. Okay. You study these things for this month. Very good. And then you get the final suggestion and study that only before 2 3 days of exam. I will give that, and that 2 3 days you just study that and don't study otherwise. What not to do in this last month? Number one, do not roam around various Telegram and Facebook groups. Do not. That's a big no. This will confuse you, cloud your mind, and give you unnecessary questions in your mind. A lot of unnecessary things will come in your mind that will just demotivate you or make you doubt your knowledge. So don't do that. Avoid these at all cost. Just watch my videos, watch my classes, and study what I say. You will pass this exam. So that's the first thing you do not do. Number two, do not study more than I tell you, because this is not an exam that you can express your knowledge, how much you know. They will not ask you that kind of question. They will ask you some specific question from some specific topics, just a little bit twist and turn. And if you know the things I tell you very good, you will be able to answer all of those. So don't worry about those things. So these two things don't do. Study what I say. ASS scoring system 100% important. You will have questions from ASS scoring system, most probably from ASA 3 and ASF 4. But you study all of it. ASA scoring system 100% important. Glasgow Coma School, you can have one question or not, not so important. You can have just one question, so don't bother about it. If you have question from GCS, most likely you are going to have this kind of scenario. A person has GCS 8, what do you do? A person has GCS 7, what do? You intubate. Intubate. Only one question or two questions from GCS, one to calculate GCS and other this kind of question. Circulatory support for critically ill. Just remember what to check and what is our desired urine output. That is 0.5 ml per kg per hour. That is our desired urine output. When to worry, what to check. Just the way I told you in class. What to check in a critically ill patient. Others not important. Just remember pulse oximetry is not a reliable method. Just the things I tell you. Only those things. Poor predictor of oxygenation. Just remember this. Not much reliable. Not much reliable. Others forget. No need. Others forget. Remember pulmonary artery wedge pressure or capillary wedge pressure. Remember what is high, what is low. I mean, if low, then what can be the possibility? If high, what can be the possibility? They will not ask what's normal, what's this, that. They will give. Not important, forget it. Right now, just see this scenario. Others, not important. SVR, not important. Inotropes 100% important. Just the way I told you in class. Just the way I told you. And you people always ask me when to use dopamine, when to use dopamine. Didn't I tell you a lot of times when? Didn't I tell you? I can't explain all these things again and again for different peoples. I have explained all these things in classes, right? Dopamine, they will specifically mention a person is having cardiogenic pulmonary edema or cardiac failure. And what do? You need a drug that is selectively work on beta 2. That is dobutamine. And the one that in higher concentration, if they say in higher concentration it stimulate alpha 1, in low concentration it inhibit alpha 1. That's dopamine. Watch the classes, man. This is 100% important. You will have questions from here. You will have questions 100%. You will have questions from here, not one, two, three questions. From dopamine, one question. From noradrenaline, one question. From anaphylaxis, IM or subcutaneous adrenaline, one question. You will have it. ARDS, just remember this line that it due to massive cytokine release and it's a diffusion problem. Diffusion defect. Just remember these two words. Others forget everything. Not important. Pancreatitis. Remember pancreatitis that they can give it as a scenario, as the stem that having a pancreatitis, then ARDS. Clinical feature, not important. Remember about prone ventilation. Number 4. Prone ventilation. What does prone ventilation? It increases or corrects ventilation perfusion mismatch. Just remember this line. We have it in arrows. Don't worry about it. Others not important. Not important at all. Forget it. Not important at all. Severe infection. Remember QSOFA score. 100%. Only QSOFA score. Septic shock criteria. Resuscitation goal again. This one, urine output. You must see urine output. And airway management. Tracheostomy. Remember tracheostomy. What are the things you need to know from tracheostomy? It's landmark. Landmark for emergency tracheostomy and normal tracheostomy. Where do we do? Midway between sternal notch and thyroid cartilage. If thyroid cartilage is not present, go for cricoid cartilage. Not a problem. Cartilage. Both will not be an option. Midpoint and what do we pierce? Isthmus. All those questions I have told you in class. What do we pierce? Isthmus. And in emergency, what do we pierce? Cricothyroid membrane. Cricothyroid membrane. We pierce cricothyroid membrane. See, indication they will not ask. They will just ask these questions from tracheostomy, ventilatory support. Remember, what do they do? They can, not important. Guys, 1 minute. Let me just. Okay. Then trauma. These things not important at all. Trauma management. I will not ask you any question from here. Only just remember G says 8 intubate. Then other things. Tension pneumothorax. Let me tell you. We have it later on. We will tell you from there. This management of bleeding not important. Nothing will ask. Nothing they will ask. Common vessels injury. Remember occipital artery. This one. Remember occipital. This one. Okay. Then others not important. Use ibutranix acid. Just remember these two lines. Remember these two lines. Then thoracic trauma. Traumatic pneumothorax. C. Pneumothorax. Tension pneumothorax. Hemothorax. Study the things I told you in class. What do? You study this. You study this. These are 100% important. You will have questions from pneumothorax, tension pneumothorax. What do? Needle decompression in second intercostal space. You will have this question in your exam. Needle decompression in second intercostal space. You will have this question in your exam. And then, and chest drain. What do? Where do you give in safe triangle? Safe triangle. Remember, safe triangle. You give chest drain in safe triangle. Remember this. Then hemopericardium, not so important. Give a reading. Flail chest, 100% important. Remember the serial, what did I say? Rib fracture is very important. Single rib fracture. Single rib fracture is not flail chest. Single rib fracture is not flail chest. Single rib fracture, if young, give analgesia. Young athlete, discharge. If old, give analgesia and observe. And flail chest, three consecutive ribs, two segments. They will tell you 5, 6 ribs fracture. I have told you several thousand times. Thousand times throughout the course, I have told you this thing. Flail chest is 3, 4 rib or 5, 6 rib fractures. They will tell you specifically. First thing to do, give analgesia. First thing to do, lidocaine infiltration or lignocaine infiltration or anything in intercostal space or bupivacaine, whatever you have in the space, in the area, not in some other places, not in some other places, not in some other muscles, only in intercostal area. You infiltrate, okay, with analgesia. First thing you need to do, analgesia. Number two, what do you do? Okay, so this is your first thing. This is the basic. Now, let me give you two scenarios. Number one, they didn't mention anything about SpO2. They didn't mention anything about SpO2. What do you do? Analgesics. Number two, they mentioned SpO2 and it's above 90%. First thing to do, give analgesia. Number three, they mentioned SpO2 and it's less than 90%. First thing you do, then intubate, give oxygen, and then analgesia. Fourth scenario, they give you a scenario that 3, 4 days ago a person is having flail chest and he is not improving well. What's the reason? Reason is inadequate analgesia. Inadequate analgesia. So what to do now? Give proper analgesia. Give proper, do as I say. Do as I say. Give proper analgesia. Okay, diaphragm rupture not important. Traumatic aortic disruption or aortic dissection, that is kind of important. Just give a reading. Just give a reading the things I have written here. Okay, mediastinal traversing wounds. Remember, stab injury. They give you a stab injury. If unstable, give thoracotomy. If unstable, do thoracotomy. If stable, if stable, then what do you do? You do CT, angio, and of course echocardiogram. Echo. Okay. Echocardiogram to see heart function. They will not give you these questions. Not so important. Cardiac contusion, pulmonary contusion, forget it. Then these things, guys, these things. See, cardiac arrest. If they tell you cardiac arrest, remember you have to do thoracotomy. You have to do thoracotomy. Okay. Sudden development of hypoxia after intubation, tension pneumothorax. Remember these lines, they will help you to answer a lot of questions because trauma from emergency perioperative trauma, you will have 70% questions of your paper 2. So these things are very important. In abdominal trauma, remember any child with abdominal, any child with abdominal injury, first thing to do fast scan or USS. Okay. Then, if an adult have an abdominal injury, best thing to do, gold standard for soft tissue injury, gold standard for detecting soft tissue injury, adult, male or female or pregnant female, gold standard, do CT. Do city. So investigation, there is no need of extra investigation classes. What will you do with so many classes? Guys, don't waste your time. Whatever I'm telling you in class, these will come in your exam. Okay. So just remember this thing. In case of child, do ultrasonogram. And if a child is unstable, laparotomy, laparotomy, and in OT you can do USS or fast in OT. Okay, others, just remember this one. Just see this one. That packing is an option. Others not important, not important. If you have studied these things previously, you will not be needing it. This is tension pneumothorax. See this X-ray. This one. See this. This is hemopneumothorax. See this X-ray and this stem important. ARDS important. They can give you these X-rays. Only one. They give only one. Either of these three. They will give you either this one. No, in between these two you will get one. In between these two you will get one. Not important, not important. Forget burn. 100% important. What are important from burns? Burn. Okay, these things not important. Response to burn. Remember local and systemic. Just this. Okay, remember hiccup after burn is acute gastric dilatation. We have included it somewhere. Let's just write it down. Remember hiccup after burn is due to acute gastric dilatation. Okay. Remember the stress ulcer in stomach and duodenum, most commonly in duodenum. Carling's ulcer, most commonly in duodenum. Just remember it. Then depth and degree, 100% important. 100% important. First degree, no fluid for not calculated in bar percent burn punch fluid. Okay, not calculated in fluid calculation. If a person has 5% first degree burn and 20% second degree burn, only this percentage will be included in fluid calculation. Just to recap, you know it. Okay, they will not give you first degree burn. Most commonly, they give these two: superficial partial thickness, superficial deep partial thickness. What's the difference? Blister. Blister with pain. Superficial partial thickness burn. Blister with no pain. Deep partial thickness burn. Then this one. Black area, no pain. No pain. No pain. Dry, dark, leathery, hard wound. They will tell you dry, dark, leathery, hard wound. Dry, dark, leathery, hard wound. This will be your third degree burn. 100% important. They will give you questions from here. Just give a reading to this. Asterotomy and fasciotomy. Remember the difference. Fluid calculation. You will have question from fluid calculation after burn and number two burn percentage calculation. Percentage calculation. Watch our rule of 9. Calculate by this in adult. Mostly they don't give children. They just give adult. So remember that. And remember to refer. If they give child, you will see that the percentage is more than 5%. You can clearly see that. Percentage is more than 5% and they will ask you what to do. Refer. First thing to do, refer. Burn in face, genitalia, when to refer. 100% important. 100% important, you must know. And what are the things they give? They give these first three most commonly. Most commonly they give these first three. Management. First thing, cool the burn. Cool the burn. First thing, with what? Lukewarm running water, under tap water. Just give a reading. They will ask you this question and they will ask you fluid calculation. 100% important. Which one are important? Just remember this one. First one, 2 ml. First one and electrical burn. These two. They give these two most frequently. And these 14 kg, 30 kg, they don't generally give these things. Okay, and after 24 hours, these things give a reading, not so important. Then complication. Here we have these two. Very important. Very important. Okay, and remember what's the leading cause of mortality in bird? Toxic shock syndrome. Remember the organism, Staph aureus. Hypercalcemia, metabolic acidosis, they don't ask these things. Myoglobinuria is 100% important. Myoglobinuria, see urine output at least 100 ml per hour needed in adult to clear the urine. Myoglobinuria due to any cause. You had this question in April, right? Remember, everything has written word by word in my notes. If you study these, you will pass this exam. Definitely will have the same words in your exam. You will have the same kind of question in your exam. This is what? This is just pure algorithm. Okay. This is just pure analysis. ARDS, hypermetabolic said not important. Not important. ARDS, you know it, massive cytokine release. Remember about myoglobinuria. What are the questions you are going to get from myoglobinuria? They will tell you marathon runner, dark urine. What's the reason? Myoglobinuria. Myoglobinuria. What do you do? You give IV fluid, 4 to 6 liter until urine clears. Urine becomes white, and for that what do we need? 100 to 200 ml per hour urine output. We want 100 to 200 ml per urine output, otherwise that person will have acute kidney injury. And what's increased in his investigations? Creatine kinase more than 2000, or they will give you 3000, like this. Give a reading. Give a reading. Going to do a stereotomy, then you will be able to answer properly. Give a reading. In paper 2 you have to answer questions by thinking, so remember these things very clearly so you will not get confused. Then chest pain, aortic dissection, they don't ask these questions from aortic dissection, they just ask aortic dissection in a young patient. What's the reason? Cystic medial necrosis, this one. Cystic medial necrosis. Problem is in media. TR is in intima. Problem is in media. TR is in intima. We have a lecture of an aneurysm and dissection. You just watch that. Then JARD, you will have questions from JARD. You will have no questions from diffuse esophageal spasm. You can have question from Borheave and achalasia. So JARD, remember JARD, and these things will be enough to remember. And remember young 7 or 1 month old boy. Remember 1 month old boy vomits milk, gains weight. I should make it more shorter. I should not explain all these things because it will then I will not be able to cover a lot of things. So vomits milk, gains weight. That's jarred. Vomit milks but does not gain weight. Does not. 1 month old boy with recurrent respiratory tract infection. Remember, recurrent respiratory tract infection does not gain weight. Tetralogy of Fallot. Borheve syndrome. After drinking alcohol, nightclub, home, person vomiting vigorously. Remember, you will have crepitus. You will have crepitus. That is Borheve syndrome or esophageal rupture. Rupture. Without crepitus, no rupture. No rupture without crepitus. Without crepitus, no rupture. Crepitus is rupture. Rupture is crepitus. Remember it. Others not important. They don't ask. Achalasia. Remember botulinum toxin. What do we use in achalasia? And failure of, we all know what is achalasia. I have explained it. Remember botulinum toxin, how it works? It works by let's say inhibiting acetylcholine or inhibiting acetylcholine receptors in neuromuscular junction. Chest pain in pregnancy. 100% important, the things I have written here, the way explained in class. 100% important. Remember all these three with the things I have written here. With the things I have written here, they will ask you this question. And of course, this treatment and this treatment, these two treatment, they will ask you question from here. Low molecular weight heparin throughout the pregnancy and 4 to 6 weeks after childbirth. Any murmur in a pregnant woman in MRCS part A. Remember, they are talking about mitral stenosis. Any sharp chest pain in a tall written. The word tall is written. Any sharp chest pain. Any sharp chest pain in a tall person. That's aortic dissection and that's Marfan syndrome due to cystic medial necrosis. Cystic medial necrosis. Remember the tall, remember the word tall. And you can have an ECG showing MI. That's not important at all. Don't be fooled by that picture. Don't be fooled by that ECG. This is not a medicine exam. This is a surgery exam. They are not asking you to give DC cardioversion. They are not asking you to give shock. They are asking you to do to diagnose aortic dissection, or you can have MI in a lot of cases. Can have MI in a lot of cases. In case of cardiogenic pulmonary edema, fluid overload, you can have MI too. You don't need those things. You have to know only aortic dissection. You can have MI, and in pulmonary embolism too. In pulmonary embolism too, you can have ECG of MI. So anytime you see an ECG of MI, you just remember that this is a surgery exam. Either it's aortic dissection or pulmonary embolism. I have to look for these things, and you will have this clue. You will have this clue there. Don't be over smart and do these mistakes and then tell me that bhai I tried but I couldn't. No, you have no excuse to do that, because I am telling you everything that will come to exam, and you cannot fail as long as I'm living. And I'm telling you that these things are coming to your exam. You cannot fail. I dare you, you should not fail. And you have to shine my name. You don't do that. You do what I say. You pass this exam and you meet me at our celebration program. Don't do these mistakes. I'm telling you, these things will come to your exam. Imaging in pregnant trauma patient, do CT, gold standard for visceral injury. Gold standard for visceral injury. Most sensitive for placental abruption, 100% important. Emergency contact, anaphylactic reaction. You will have latex or peanut or some other history, and they will tell you perioral edema. Remember perioral. Don't be fooled by periorbital. Periorbital edema is due to nephrotic syndrome. Perioral anaphylactic reaction. What do you do? I am adrenaline. Give I am adrenaline or subcutaneous adrenaline. First thing to do, give I am adrenaline, no matter how the BP, no matter what's happening, give I am adrenaline first. These all will be corrected. I'm not going to explain these now. Hypothermia, 100% important chart. 100% important chart with the ECG. Remember it. This will come in your exam. Osborne wave or J wave. Remember, hyperkalemia. They don't ask question. Just remember calcium gluconate. What do you give? What do you give in hyperkalemia? And what do you do if it's more than 6.5? Just remember these two. Hypercalcemia. Remember just this line. What do you do? Other things will follow. This will be in one option, and if they add something, they will add with it, and those will be right. Don't get confused with other things like bisphosphonate or calcium. But remember, the option that's having 4 to 6 liter of IV normal saline, that will be the correct answer, no matter what's added after it. So from hypercalcemia, only this line. From hypomagnesemia, remember what I said. They will just tell you to diagnose. If a person is on TPN and then wide QRS interval, wide QRS, that's hypomagnesemia. If a person has had massive blood transfusion due to citrate toxicity, I told you what happens in our classes, so I'm not going to explain. Due to citrate toxicity, he or she is having these things: perioral paresthesia, Shopstick sign, and carpopedal spasm. Perioral paresthesia, carpopedal spasm, and Shopstick sign, plus white QRS. So white QRS, if you have these things with white QRS, that's hypocalcemia. If you have TPN with white QRS, that's hypomagnesemia. Not important. Acute intermittent porphyria. Perioperative and critical care. Local anesthetic agents. Remember how they work. They block voltage gated sodium channel. All three. Remember how they work. Not important. Not important. Remember these are amide. Only cocaine is ester. Not important. Not important. And remember this one blocked by dopamine and serotonin marked vasoconstriction. Then dose. Remember the dose calculation, 100% important. And remember bupivacaine dose cannot be increased with adrenaline. Others not important. And remember what's the antidote? Intralipid 20% for all. Okay. Do not use adrenaline in 100% important. ZX procedure, person having severe HTN and arrhythmia. Not important. General anesthetics, ketamine, 100% important. Others, you can give a reading, but not so important. Muscle relaxant, 100% important. Both etracurium, pancurium, vacurinium. And remember, neuromuscular blockers, depolarizing is succinylcholine. And what about other succinylcholine? We have it later on, maybe not so important. Malignant hyperthermia, remember agents, these things. And these are depolarizing. Depolarizing. Okay, these are depolarizing. Malignant hyperthermia and the others give a reading. They don't ask question. Not so important. Just remember the names of the agents that can cause malignant hyperthermia. Pre-operative checkup. See, remember about diabetic patient and this one, 100% important. More risk of infection, more risk of delayed wound healing. And these warnings: do not give carbohydrate, do not stop insulin. These will help you to take decisions and they will give you decision questions. You remember these things and you will not be having any problems. Any problems. Not important. Just remember problem with aortic stenosis. Remember problem with aortic stenosis. This line. Vascular disease, not important. You know about stocking. In vascular surgery, I will talk about the drugs guideline. Remember when to stop warfarin, low molecular weight heparin, when to stop aspirin, when to stop dabigatran, when to stop clopidogrel. There's a when to stop the coccyps, when to stop Rolac, everything. Everything you should know. Everything you should know. This is the range, and you will have any any number in between this range. Okay, you get that number in between this range and you select that, when to stop. They will ask you when to stop. And steroids due to these two line, 100% important, 100% important. Steroids due to RABA, increase dose and continue for 3 days. Insulin do not stop. Drugs to start before surgery. Major surgery, orthopedic, vascular, abdominal surgery, and one dose before OT reduces infection rate. Okay, these things. And bridging. They will not ask you about bridging. They will just ask you about emergency procedure. Emergency. What do you give? Like a person with strangulated hernia came to surgery on warfarin. What do you give? PCC. Just remember what do you give? PCC. Simple. Okay. Others, they don't give those things. If it's 4, I mean less than 5, just stop warfarin. Between 5 to 10, stop warfarin, give vitamin K. K. If it's not an emergency, no emergency operation, no emergency OT. So that applies for that. More than 10 INR. How do we keep track? We check INR. So this is INR. This is INR. INR 10. More than 10. Give PCC plus vitamin K. And emergency operation. Give PCC. Do operation. We will see about vitamin K later on. INR. What is our target INR? Remember this. 2 to 3 is our target INR. Special check before surgery. Vocal cord check. Remember this one. Others not important. Remember this one. So before thyroid surgery, you must counsel the patient about vocal cord paralysis. Vocal cord paralysis. Must counsel the surgery about vocal cord paralysis. Here we have it. 100% important. Remember this. This will give you confidence and some questions. Also, thromboprophylaxis in surgical patient, high risk group, not important. They don't ask any direct questions. Mechanical thromboprophylaxis, this one 100% important. 100% important. How we can do mechanical thromboprophylaxis? Early ambulation after surgery is cheap and effective. Remember, compression stocking, contraindicated in peripheral arterial disease. You must remember this line. They will tell you lifelong smoker. That means COPD. No compression device, no stocking, no stocking. Or history of IHD, no stocking. This is not the time to explain these things. I have already explained it. These will just waste your time. So pneumatic, remember these four. Very important, very important, very important. So others not so important. Give a reading. Not so important. Reversal agent. Remember reversal agent. Very important. Very important. Remember reversal agent. Reversal. Bowel preparation before surgery. Just remember sigmoidoscopy and colonoscopy. If there are any iron supplements, stop iron supplements. Hypothermia before surgery, 100%. You will have questions from here. Hypothermia before surgery and normal hypothermia is not the same. In ward before OT, if temperature is 35 degrees Celsius, warm by bear hugger, incident report, do incident report, then do the operation. If 34, no OT, no OT at 34 degrees Celsius, cancel the OT. Cancel the OT. If 35, you warm by bear hugger, and then you can do the OT by, and at the same time, you have to report it as a critical incident. And if 34 or under 35, first thing you do, cancel the OT. Cancel the OT. These three things should be done simultaneously. There is no serial about it. Cancel the OT, give warm IV fluid, give warm IV fluid, report critical incident, report critical incident. Now 34 with emergency strangulated hernia, give warm IV, report critical incident. Then after a little bit, if possible, then do the OT. If it's emergency, then do OT. But if it's elective, under 35, cancel the OT. If it's elective, under 35, cancel the OT. And after OT, temperature 35, what do? Give warm blanket, give warm IV fluid, wait up to temperature becomes normal or 36 degrees Fahrenheit. Before reaching the temperature 36, patient will not get outside the OT. Patient cannot be shifted to ward if temperature is not 36. You can just give a reading if you want. Then fluids, crystalloids, colloids, they will not ask you. They will not ask you these things. No, they will not ask you these things. Remember, if they ask you about highest sodium concentration, you will see the options will be understandable. Understandable. So don't worry about it. Remember, fluid having highest sodium and chloride component almost 153 ml per 153 millimole per liter. Okay, 153 millimole per liter in 9% saline. And in Hartmann's 131 or 130, whatever you say. Then these things not important right now. Not important right now. Forget. Forget. Fluid input output chart not important right now. Not important right now. Not important. Nothing will come in your exam. Daily requirement. Remember this requirement 100% important. Then you will have questions from fluid. You will have questions from fluid. Okay. For resuscitation, what do you do? For resuscitation in a hypotensive patient, what do you do? Give 500 ml Hartmann's. If Hartmann's is not in your option, you can give normal saline with and check urine output. Okay. Vomiting, give normal saline with potassium replacement. Diarrhea, ileostomy, give heart salt. Blood loss, give blood. If not available, heart salt. Right now, these things are not so important. Remember, they will not ask you about term, pre-term. Just remember, 1 year or 9 year old boy is having appendicectomy. Analgesia, paracetamol. Fluid, 0.9% sodium. Just remember this one. Other things not important, forget it. Maintenance fluid. Ideal maintenance fluid. Ideal maintenance fluid. 1 liter heart sol or 1 liter normal saline plus 1.5 liter 5% dextrose. Okay, dextrose in aqua, dextrose in this, that not important. They will give you directly this one, this word only, 5% dextrose. Then child, remember holiday Segar formula 4 to 1 rule, 500 ml, 50 ml. You will have questions. You will have question from a child maintenance fluid and resuscitation fluid. Just 20 ml per kg, just multiplied by 20 ml per kg and you will have your answer. And maintenance fluid 100, 5, 20 or 4 to 1, the way I have taught you in our classes. Neonates, they don't ask, can give a reading. You can give the reading. And this one, of course, very very important, 100%. And see these examples I have given you. You will have questions from these things. You will have questions from these things. You will have two questions from here. Two questions from fluid. You will have two questions from child. Let me tell you what are the things you are going to have. From fluid, you will have a resuscitation fluid. Which one? 500 ml bolus and check urine output. Then you will have questions about ideal fluid, ideal replacement fluid. Ideal fluid for replacement. 1 liter heart sol or normal saline with 5% DNS, 1.5 liter. Sometimes they give 1 liter. That will be a right answer too. Because you will see other answers will not make sense. You will have child maintenance fluid. You will have child resuscitation fluid. So you are going to have a lot of questions from fluid. You will have burn fluid calculation. How much you will give in first 24 hours, or they will give you how much you will give in first 8 hours. So that's how they want to trick you. So you are getting a lot of questions from fluid. Don't make a mistake with all those things. Not needed. Not needed right now. Enhanced recovery protocol, 100% important. You will have questions from enhanced recovery protocol. Remember about carbohydrate loading and no carbohydrate loading. Diabetic patient, no carbohydrate loading. Remember OT temperature should be 21. Then remove NG as early as possible. Just remember this statement. In your exam, whenever you see this statement, you just select that. Remove NG as early as possible. Remove NG ASAP as early as possible. Mobilize the patient as early as possible. What's the benefit of ERAS? Reduce hospital stay by 30 days. Remember, preoperative benzodiazepine, preoperative antiemetic not included in ERAS. Then IV access, not important. Hemorrhage and infusion, like these are not important for this September. It's not like these are not important for next January. They can. I will analyze those questions later on and then give that solution before January, right? So hemorrhage and transfusion, remember this one, 100% important. Blood transfusion, remember what will be the infective organism, gram negative organism. Just remember gram negative organism, that will help. Store at 4 degrees Celsius, RBC products. And platelet and platelet products are stored in room temperature, almost 24 degrees Celsius. That's why it is contaminated by gram positive organism. And remember, platelet products does not need any cross matching. Then, but cryoprecipitate, we must cross match cryoprecipitate. And you must remember the contents of cryo. Okay, contents of maybe factor 8 or what. You must remember the cryo contents, cryoprecipitate contents. Remember those. Complications of blood transfusion, 100% important. You are going to have cytotoxicity. You are going to have cytotoxicity questions. You are going to have cytotoxicity questions. And you will have another question. 3 months after blood transfusion, jaundice. That is hepatitis C virus infection. And what's the most commonly transmitted virus in needle prick injury? Hepatitis B. Hepatitis B is the most commonly transmitted virus in needle prick injury. General complications of blood transfusion, 100% important. Transfusion specific complication, 100% important. Remember all of those. Though I can tell you that sometimes they don't give all these things, you can just study, like not here, not here. You can just study. These are just give a reading. Other complications, just give a reading. But you must study these things. ABO incompatibility, what type of hypersensitivity. Okay. And you know these things. Transfusion associated circulatory overload and transfusion associated lung injury. This one not important. Just this one. Delayed complications. Remember these two. Graft versus host disease and jaundice. And jaundice after 3 months is hepatitis C. Others, iron overload and infection, not important, guys. Not important. They will not ask you. Trali and taco, just give a reading. You know what I told you in class. And these 100% important. They give you specific question mentioning what type of hypersensitivity reaction is this. What type of hypersensitivity reaction is this? Just this line, these two lines. Before exam, just these two lines from these columns for this chart. Others you can give a reading or you can just ignore. Not a problem at all. Cell saver devices, they will not ask. Just do not use in. Where we should not use in. Remember it. 100% important. Tourniquet. Just remember exsanguinate. Inflate the cup above 16. Exsanguination after inflation of the cuff above systolic. Okay. And when the tourniquet is released, which one causes vasodilation? Remember it. Histamine. Histamine. These give a reading. Not important. These not important. Not important. They don't ask. They don't ask. Not important. For your September exam. Factors promoting thrombosis. Not so important. Not important. Von Willebrand disease. Just remember this one. This not important. Just remember this one. Bleeding postoperatively. Epistaxis, menorrhagia. Bleeding time, APDT increase, platelet count normal. That's von Willebrand disease. Some points to remember. Anytime I have written something and I have written that some points to remember or remember, that is 100% important. Very, very important for your exam. Remember every single line. Then pain management. Pain management, the way they don't ask these things. They don't ask these things. They don't ask these things. Pain management, remember what I told you in class. Remember pancreatic carcinoma and acute pancreatitis. Remember about orchidopexy and hemorrhoidectomy. And of course, herniatomy. Okay. Then Metastatic bone pain from carcinoma prostate, bony metastasis. Initial, you can use paracetamol or NSAID, but if they ask about what's best, that's radiotherapy. Okay, abdominal surgery they will not ask. Forget it. Most commonly given is epidural. After abdominal operations, most commonly given is epidural. Just remember this as a statement. Nothing specific. Okay, chronic pancreatitis with back pain. This is important. Acute and chronic pancreatitis. In acute cases, you can start with paracetamol. Then you can give celiac plexus block. Okay, you can give celiac plexus block. Mm, okay, you can start with paracetamol, but inside these days they are giving new studies, and all of the studies are against NSAID. So I would suggest that don't choose NSAID in your exam. You will have either paracetamol. You always, like, this is a bias for NHS. Okay, so they don't like NSAID. So if you are confused and you don't have any appropriate option, you don't choose NSAID. Go for paracetamol or celiac plexus block. They generally don't give NSAID anymore. Okay, celiac plexus block. Or even if you don't have those, go for pethidine. Go for pethidine. Paracetamol, codeine, pethidine. Avoid NSAID and morphine in acute pancreatitis. Acute pancreatitis. I have seen some recent studies where they didn't like these things. So avoid this. And just last week I have seen those. So I'm just telling you to follow that, because according to newer studies they change the answers. Open resection of carcinoma, splenic fracture, and respiratory compromised. Hmm, So epidural, not a problem. Appendicectomy, PCA. Okay, abdominal surgery, you can give epidural. These are not so important. Okay, just appendicectomy with PCA. And remember, if it's a Down syndrome patient, you can still give PCA. After appendicectomy, you can give PCA. Appendicectomy, give PCA. Neuropathic pain, 100% important. They will ask you question up to referral. Up to referral. Okay, they will tell you that you have given amitriptyline, didn't work. What do you give? You give pregabalin. Or they will tell you that a patient with diabetes mellitus and having neuropathic pain, he is having postural hypotension. What do you give? You give pregabalin. Then they will ask, did not improve. What do? You refer. You refer this patient. And of course, remember, diabetic patient. Of course, this will be diabetic patient, right? Neuropathic pain in a diabetic patient. Most of the time, it's diabetic patient. In case of you can give doluxetine too. Then, in case of appendicectomy, PCA is very popular. Okay, post-operative complications. From post-operative complications, you have to remember day one. Any problem in day one, remember it's atelectasis. Any problem in day, they will give you day seven. Then infection. Infection. Okay. Five, DVT. You can remember from this chart too. Remember from this chart too. This will help. Okay. Then they will tell you about post-operative ileus. Just give a reading. This green line, study this green line. Okay, and postoperative ileus, I have told you that postoperative ileus is mostly due to dopamine. Remember this line. Anastomotic leak, you can, yeah, anastomotic leak is important. Okay, anastomotic leak, just remember that. How do you, they will give you a scenario like this: esophagectomy, then the drain has chyle in it. So there's a is a perforation, or they will tell you that you have anastomose and some fecal material is coming out. So there is anastomotic leak. And they ask you about the feeding method. They ask you about the feeding method TPN. They don't give anastomotic leak questions like what do you do now. They just ask you about feeding options. Give total parental nutrition. This is 100% important. You will have question from total parental nutrition, mostly from colon resection. Okay, mostly from colon. They will give you that carcinoma. Most important, remember stroke, peg. Remember stroke, peg. Head injury waiting for discharge, NG. Head injury, slow recovery. They will mention slow recovery. Give nasojejunal. Okay. Any perforation, chyle leak, anastomotic leak, TPN. Okay. Then total ileum resection. You will have this question in your exam. More than 200 centimeter enteral with special formula. 100% important. Refeeding syndrome. Not so important. Just remember what are the metabolic consequences. Other things you can just give a reading. Give a reading. Not important. Postoperative ilia studied from here. If you want details, you can study details, but they don't ask much details. They will just tell you what will be the findings. Okay, what will be the findings? And confirmatory test would be this one, a CT scan of abdomen and pelvis, often with oral contrast. Then conservative, and remember its management is conservative. Nothing per mouth, give TPN, and then daily blood, including give a reading. Not important. Just remember the management is conservative. That's it. This one, give a reading. Anastomotic leak. Nothing to study from here for this September. Okay, you can just give a reading to this thing. And surgical factors, they will give you this in STEM. They will mention these things in STEM, and now they will tell you that there is some discharge. Okay, then prolonged ileas or these things, tender abdomen, and you will diagnose it as anastomotic leak. Okay, other things not important, they will not ask you much. Wound dehiscence, just remember this thing, pink serous or bloodstain fluid from the wound. Just remember this. Incisional hernia, just remember this. Give a reading. Give a reading. Then scar. In hypertrophic scar, first line. Keloid scar, first line. And treatment. Where is the treatment here? Uh, okay. Just remember treatment for keloid. Remember we can give triamcinolone. They mention this triamcinolone injection inside the keloid. Other things not important. Then orthopedics. So from orthopedics, from shoulder disorder, I have explained this in painful arc syndrome or all this in our orthopedics class. I'm not going to explain this. Remember, what are the things that are important? Frozen shoulder is important, painful arc is important, supraspinous ST are important, osteoarthritis 100% important. Say mostly secondary osteoarthritis. Remember what I said? 4 5 years after pain on the same fracture site, that's secondary osteoarthritis. Are and primary or normal osteoarthritis, just narrow joint space. Remember, narrow joint space is a very unspecific finding. So you will see that in knee, old age, and no other clue. No other clue. Knee pain in old age is mostly osteoarthritis. Shoulder dislocation, they don't ask these questions anymore. Remember about rotor cuff, 100% important. 100% important. They give you question from this chart. From this specific chart, they will give you question and they will ask you its action 2. They will ask you its action 2. Then Remember the difference. Remember this. Remember this. Subacromial impingement, rotator cuff, TR, frozen shoulder. Then eponymous fracture. From eponymous fracture, they don't uh, much questions anymore. At least in September, they don't give much question from eponymous fractures. They don't ask about that. They give that Colles fracture. Then after 3 to 6 months, 3 to 4 months, pain. What is that? Malunion. They give malunion question. Not so important. Just remember green stick fracture. Others not important. Can give a reading. Just remember green stick fracture. Others not important. Like all those beautiful things, Smith's fracture, Colles fracture, not important for September exam. Montezia and Galeazzi fracture. These are also not important for September exam. Not so important. If you have studied previously, if by chance anything comes, that will not come. Still, you will be able to answer because there's nothing. There's nothing for in this September. They will ask you about nerve injury and Holstein Lewis fracture. Remember Holstein Lewis fracture and radial nerve is injured. Then March fracture is important. 100% important. March fracture is important. 100% important. Hip fracture treatment. Remember Garden's classification of hip fracture, Powell's classification, forget it. Then hip fracture, this one intracapsular, extracapsular. If you have studied previously, you don't need anything right now. Presentation, this is important, 100%. Externally rotated, shortened leg, hip fracture. And medially rotated, shortened leg. Medially rotated, shortened leg, posterior dislocation of hip. Dislocation of hip, injured nerve, sciatic. Management. Management is 100% important for neck of femur fracture. You will have questions from here. Extracapsular fracture, not so important. Still, study it. 100% important because they give equally questions from here in September. Equally. So, both. This is an 100% important page. 100% important page. Everything written, study it. Then the things I have skipped them intentionally. You don't need those. You don't study those in this last month. Don't waste your time. Hip dislocation only, posterior dislocation 100% important. Every tear about knee is important. Every tear. Patella fracture, chondromalacia patelli, Osgood sclature, except hemophilia. Hemophilia too. Hemophilia. And remember what I said about quads rupture, quadriceps rupture. If you can't remember, watch our orthopedics class again. Quadriceps rupture, because I will not be able to complete all of it if I start explaining all of it. You will have question from knee, at least two questions. You will have at least two questions from knee injury. The things I'm skipping intentionally, nothing needed here, nothing needed here. Just remember anterior drawer test is done for ACL injury. Posterior drawer test or SAG sign is related to PCL injury, posterior cruciate ligament injury. And about angulation, don't ask me any question about angulation anymore. I have explained a lot of times and beautifully. Okay, so medially rotated, medial collateral ligament injury. Laterally rotated, lateral collateral ligament injury. Don't ask me again. McMurray test done for menisci. Just remember McMurray test done for menisci. Patience arenas burst is not important. Tibial plateau fracture, Schatzker classification not important. You can study Gastillo Anderson classification of open fracture and what to do. This one 100% important, but Schatzker classification not important. They don't ask. Ankle Dennis Weber classification, give a reading, not so important. Give a reading. This one is important. If inversion injury. Inversion injury, which ligaments are torn? Anterior talofibular, calcaneofibular, and Posterior talofibular ligament. Where is posterior talofibular? We can't see it here, but we also know that posterior talofibular ligament. These three are torn in case of inversion injury. And in eversion deltoid, not so important this one, but this one is important, 100%. Types of ankle sprain, nothing needed. Just remember what to do. Rise. Rest immobilization, rest ice compression, elevation. These things are also important, guys. Just remember rise. Achilles tendon rupture, just this is 100% important. You must know it. Even if it comes or does not come in your exam, you must know it. You have to know it if you want to give a MRCS exam. Simple as that. Then what test we do? Simon's quiz test. This one not important. You can just give a reading. Then foot, Morton's neuroma, 100% important. Don't confuse it with March fracture. Remember it. Then hand, Dupuytren's contracture. Just remember the treatment of Dupuytren's fracture. What to do? Needle fasciectomy. Then the nodes. Signs of osteoarthritis. History of previous trauma or chronic joint infection. Then trigger finger. Symptoms. Remember the symptoms of trigger finger. And this one. Just remember swan neck deformity. Hyperextended PIP and flexed DIP. Others not important. They don't ask. Scaphoid fracture 100% important. 100% important. The things I told you. Lunar dislocation 100% important. The things I have told you. Remember loss of sensation in first three fingers. This one. Just remember this line. Okay. Others. Remember the X-ray. What X-ray we will give. What X-ray is? Be a true lateral view. True lateral view. Will show Terry Thomas sign. Not important. They don't ask. Pediatric condition, buccal, thorax compression, just remember green stick. Others not important, they don't ask. Non-accidental injury, give a reading. Sometimes they give this. Then Gartland classification of supracondylar fracture of femur, they don't ask, but they ask which structure will be at risk. Which structure will be at risk, AIN or median. So all of the structure can get injured. Salter Harris classification. Just remember which two type will look the same in X-ray. Type 1 and type 5 will look same in X-ray. Just remember this statement. Then other, you will have question from DDH, Perthes disease, slipped upper femoral epiphysis, septic arthritis, and transient synovitis. All of it are important. You will have two questions from ankle, one question from here. You must have one question from here. Two questions from ankle and one question from here. You must have it. And you will have an X-ray of Perthes. You will have an X-ray of Perthes disease. We have X-rays in our flashcard. Watch it. You will have an X-ray of Perthes disease if they give it. Give braces. Correction with braces. Just remember it. Pathological fracture. Osteolytic, osteosclerotic, mixed. Give a reading. Bone disease, osteoporosis, osteomalacia, rickets. Just remember osteoporosis. Bone mass decreased, mineralization normal, normal calcium level. Just remember this line. Just remember this line. Then rickets, vitamin D deficiency not important. Give a reading to others. Give a reading. Not important. Remember Paget's. Just remember this line. Just remember this line. Fracture healing. 100% important. They give you these questions these days. Which reduction method promote primary healing? Which reduction method promote secondary healing or callus formation? No callus formation. Callus formation, and this is the secondary or indirect healing stages. Remember the stages, just the headline: soft callus, hard callus, bone remodeling, and the time frame. Hematoma formation first week, 2 to 3 weeks. Hard callus 3 to 6 weeks, and then bone remodeling will be taking 8 weeks to 2 years. Complications after fracture. persistent pain at fracture site, and sometimes it's painless. Most of the time they will tell you all this fracture site and no sign of union, no callus formation. But here you will have deformity and pain on movement, and non-union. Most of the time you will have no pain and sometimes persistent pain and no sign of healing, and there will be movement in the fracture area. Okay, then fat embolism, pulmonary embolism. Remember what I said, 100% important chart, 100% important chart. Remember all of these things, 100% important. All of these things you must remember. And these are the important investigation. No trauma, no evidence of fracture, pain doesn't go, joint pain, do MRI. Most of the time they give ankle scenario like this. Remember it. Okay, bone tumors, forget it. They don't ask any question from it. They don't ask. They don't ask. Chondroblastoma, giant cell tumor, no questions will come. Chondrosarcoma, osteochondroma, no questions will come. Only Ewing sarcoma. Study Ewing sarcoma. And sometimes they don't give any question from Ewing sarcoma too or osteosarcoma. Ewing sarcoma, osteosarcoma. Ewing sarcoma, osteosarcoma. Only these two. Others not important at all. Not important at all. Most common bone tumor. If they mention a round monotonous blue tumor, that's Ewing's sarcoma. Okay, Ewing sarcoma. Now, if they mention that's Ewing sarcoma. And onion peel appearance, sometimes they mention, sometimes they don't. But remember, if you don't, if you get a question about bone tumor and you don't understand what to answer, answer osteosarcoma. This is just a hack that if you don't understand which bone tumor they gave, answer osteosarcoma. They will tell you osteoid formation. And of course, there will be soft tissue invasion, right? There will be soft tissue invasion. And they will tell you that a 17-year-old boy, what's the most common type of cancer in a 17-year-old boy in bone? Osteosarcoma. Osteosarcoma is the most common type of bone cancer in a teen-aged boy. So telepathic equinovarus, just remember the features. Not so important, still not important. Spine disorder, 100% important. You must know canal stenosis, spondylolysis, spondylolisthesis, and slip disc. And remember this line: pain worsens when standing for long period. Sorry guys, standing for long period of time, walk or downhill. Okay, and pain increases going uphill. Going uphill increases pain. That is slipped disc. Going uphill increases pain. That is slipped disc. Or going uphill relieves pain. That is lumbar canal stenosis. Lumbar canal stenosis. They will ask you this question. And of course, what's inside? Which part is in case of spondylolysis? Which part of the vertebra breaks? Remember, pars intercularis. This part breaks. This part breaks in spondylolysis. Okay. Scotty dog appearance in X-ray. Okay, spondylolysis. This is the break. And what's listhesis? The vertebra has slided forward after breaking. The gap increases. That's listhesis. Simple. And remember prolapse. Remember prolapse. Which part prolapse? Nucleus pulposus. P for pulposus, P for prolapse. So nucleus pulposus prolapse. And which one's deficient? Annulus fibrosus. Annulus fibrosus. Which one's deficient or weak? Annulus fibrosus. Simple as that. Nerve root compression. Every nerve root you must know by heart. Every nerve root you must know by heart. Then lower limb compression also. Every nerve root. Sensory. Muscles not important, but This one, sensory, you dermatom, you must know. Okay, and remember about jerk. If anterior thigh plus knee jerk gone L3. If knee jerk plus medial leg sensation gone L4. If only knee jerk mentioned L3, L4. If they ask dorsum of foot or dorsiflexion gone, nerve root involved L5. If they ask lateral side of foot or heel of foot gone S1. If they ask ischial tuberosity S3, medial malleolus L4, lateral malleolus L5. Only the things I mentioned, you study this. If you have dermatome questions, you will have question from only here. From only this chart, you will have this question. That's how we end our rapid revision one. We will take our take exam on these topics only. Best of luck, guys.